Hello, everybody. My name is Hao. I am your occupational therapist. And with me today is a colleague of mine. Her name is Weng. And she is an occupational therapist as well. So this is an interesting conversation because today we are going to explore occupational therapy cover in a major trauma service. Okay.
Pediatrics.
In pediatric. So pediatric major trauma service. There's no major trauma service yet in the region where I am working and we are working. And so now we're really exploring it. There is a need to have an occupational therapy in the area. But then the question is, where do we go and what do we do? It's a big question, isn't it? Isn't it?
Yes, it is.
It is. And Weng, tell me, what are your challenges at the moment?
Well, I've been approached to provide my input in this business case. So
Okay.
we're trying to promote occupational therapy and include occupational therapy in the business case for the major trauma. Because at the moment, we don't have a ring-fenced time for pediatric OT in major trauma.
Okay.
There's only one OT that
That's
covers
yourself?
the whole ward.
Uh-huh.
Yeah, all of the children's wards across all specialities. And what happens is once there is a major trauma pediatric case, they get referred to the occupational therapy team. Well, there's just one person, so
Yeah, which
it's,
is yourself.
Yeah, and that gets triaged and prioritized. But again, it depends on the availability and the capacity of the OT.
Okay.
The challenges I face are one is timely response.
Uh-huh.
Because once we get a referral, I don't really get to see them on time. Well, it depends if I'm around and I have the capacity to do it quickly, then I will. But if I'm not around, like I'm on annual leave or I'm on sick leave or I'm cross-covering or doing other parts of my role, then the child don't get seen straight away. So the job that OT is supposed to be doing are divvied up to the physios, speech and language, nurses. We kind of lose our role there,
Wow.
which is
It is sad, isn't it?
sad. And
It's almost sad.
yeah,
Because you're an occupational therapist and you know what you need to do. But then, because you're not there, the responsibilities are now being taken over by the other multidisciplinary team members, isn't it? So we get divvied up to the physio, to the speech and language, to the nurses. And then when you come over, it almost feels like you are just there to provide equipment
Yeah.
because they've identified the concerns already.
exactly. And I don't like to be identified as just the equipment provider because we're not. It's not the role of. It's not just our role. There's so much to it that's missing, and basically we are needed from the very beginning.
Exactly.
From the very start, when the patient's in, you need to be there and do your assessment. And I have two cases that I'm comparing at the moment. So one's when there wasn't an OT at all to cover, and then the second's when I came in and there is now partly an OT
Okay.
in the service. So, and then the team recognized that actually they see the difference of having an OT and not having an OT, and they were telling me that there's a big impact on the time, length of stay, on the safe discharge planning, and so now they have approached me to
Put in a business
put in
case.
a business case for occupational therapy to be included
In the major trauma.
major trauma. So there's going to be a ring fence time for OT. And that's another big challenge for me because I am there clinically. I'm not supposed to be doing this. My job role doesn't include this kind of service because I feel like this is beyond me. But who's going to do it?
I feel you. I really feel you. Okay, this becomes, ladies and gents, listeners, it becomes more of a OT counseling between two colleagues. And let me just do a recap. Our first objective here and the first reason for this conversation, OT conversation, is about occupational therapy in a major trauma. But then, on the starting point, and, the way I hear you and how I hear you is that there are bigger problems here, and that there is so much demand from an occupational therapist for occupational therapy service, and you are just the only person in the unit that has to cover multiple areas. Okay. Okay, we'll set that aside for the time being, the multiple and all the other areas. Let's just explore what we can be doing from an occupational therapist, from an occupational therapy perspective in a major trauma unit. Actually, I was trying to draft some of the, like a paper here or some editorial or some reflective piece. It's just what I do every day, isn't it? OT, I work as an occupational therapist, and it's a leisure and it's a hobby. So occupational therapy is the occupation, okay? And so I'm just trying to draft, and I thought this is really big. And even me writing it down, I just felt that it would be better if we can have this conversation. When you see, let's take a picture of, let's have a picture, an overview of what can happen, whenever there is a major trauma. So obviously, major trauma would cater to...
It will fit into a lot of specialties. So major trauma can be, so once for example, a child is brought in following a road traffic accident.
Okay.
So they get to A&E. They get assessed there by A&E doctors. And depending on the severity of the case, what specialties will be needed. So they would probably call in orthopedic,
vascular
surgeons, neuro surgery. If there is a what do you call this?
Respiratory.
Brain injury.
Plastics,
respiratory. Yeah, that's a lot.
That's a lot, isn't it? And it's always unpredictable, isn't it? I think this is the first phase, So major trauma, I think we're talking about physical trauma, isn't it?
Yeah.
And a major physical trauma would stem out of a major accident. And particularly the primary accidents that's happening is road traffic incidents. I can see that perhaps a... sports injury can happen here, where you can have a bad problems, say head injury or a spinal cord injury or a big fall from a high level, for example. So that these are all like traumatic events that can cause physical trauma, but it's not psychological trauma, isn't it?
No, there's no psychological
trauma.
So down the line they will have that kind of support, but we're just talking about the acute major trauma, physical side of it.
So I was thinking about it, and the first trauma is as soon as you get to A&E, and you were right, I was just thinking about this. And when the person comes in, had a major incident, gets ambulanced in or taken in by an air ambulance into A&E, and then that depends on who needs to be called, isn't it? So I would assume that the service would have emergency doctors on standby every time as to who needs to be called, isn't it? Whether it's vascular, because as soon as there is an injury, and this is not just pediatrics, isn't it? It could be their parents as well. It could be a major, when it happens, there could be multiple people in the injury. So the first phase is really time specific. And I think what's important is control the vascular injuries, make sure that there is a cardiac. I'm just anticipating what the doctors would do, isn't it? Anticipating the stabilization of airway, cardiac, vascular capacities of the child. They would control muscular and soft tissue injuries because they're the ones that are causing bleeding, for example.
There will be a full team of them. There'll be nurses, everybody in there.
Okay.
And once they're stable from A&E, then they get to the wards or ICU. It depends on.
Right. So that's the first phase, the A&E. And I am envisioning, based on this, if there is an occupational therapist in that particular service, an occupational therapist can be, although it's not actively involved, OTs are not actively involved, in here, once the OT in this major trauma is alerted of the case, you already know what's happening. You already know, you can already anticipate that patients would be coming. And in doing so, you can look at, you know that there's a child that's coming, and you can identify the age, you can anticipate. I think in this stage, it's anticipatory stage, from an occupational therapist. And there's an A&E, you heard about it, you can write down the case, you can be on standby. Because the first stage, once they've optimized the child or stabilized the child, okay, the next stage would be to go into critical care. And again, being part of that team. So I think on this anticipatory stage, as an occupational therapist, you need to have multiple skills, don't you? You need to have the skill of neurology. You need to have orthopedic skills. You need to have, surgical skills, isn't it? So it's a high clinical skill. It's not just discharge planning that we're just going to talk about here. We are going to talk about anticipatory. We are going to talk about rehabilitation as well. So early identification on the first phase. Say there's an incident, you get called, you have a bleep, you know the case, you can write it down on your caseload straight away. So without the OT on this phase, then what can happen is that the MDT somewhere down the line will have to make time to refer them over to you.
Yeah, that's what's happening at the moment.
That's what's happening.
So they do everything else, and once the patient's stable, they go to ICU or the ward, but most of the time ICU. Even within my role at the moment, the capacity isn't there. I can't even get involved in the ICU. So we're down to the ward level when they are more stable and there's not much. It's just this discharge planning and rehab. If identified as rehab potential is good, then we get involved in that level too. But it's not as, timely as I see it. It's,
Okay. Well, I'm looking at it from what should happen. What is the best thing that can happen? If we were there, and if we're not worried about what we have now, if you're not worried about your the level of capacity, yes, that's a problem. There's only one of you and you are the team. Yes, we cannot do that. But if there is potential investment in here, and there is a team of major trauma team, whoever is leading this is already aware. Be alert, somebody is here, then you can already find out the name of the person, the age of the person. You can anticipate if they're 16 years old or 5 years old. You can already have a picture of what's going to happen. And then you don't have to be involved in the A&E because that's a very busy place. But as soon as they go on the next stage, which is now the recovery or intensive care stage, then an occupational therapist can start coming in as well.
Oh, yeah, definitely.
So ideally,
you need to be involved in that
I
stage.
see. Yeah. So it's a pediatric critical care. Exactly.
Yeah.
Yeah. From major trauma, critical care. It's not because of a critical care illness, but it's going to be another department technically. But it's a major trauma, so it means you'll have to be looking after your team. Let's imagine that you have a big team. We'll have to be coming into that critical care stage, and on that critical stage, now occupational therapists then can now do physical assessment, isn't it?
When we have children referred from major trauma, I get involved in the ICU stage.
You do?
I try. That's the quickest. I prioritize that because that is essential. Unless I have more than one of them, which is going to be a challenge. But that is what I am aiming for, to be there during the ICU stage.
Okay.
Especially when there are other adults involved, and get them on time, really getting history and assessment process starts there.
So you get there. So you already have been doing it.
I have been,
but not in a full swing.
No.
Okay.
And it's really an effort.
It's an effort.
It is an effort.
So what do you do? What do you do in critical care?
In critical, well, history taking.
Okay.
Yeah, initial interview with whoever is there. If parents are not involved, it's just the child there, then parents, of course. But if parents are also...
Do you call the parents?
Yeah.
Okay.
Yeah, we catch the parents there,
Okay.
or whoever. There is a time for them to visit.
Okay.
So parents or any relatives or anybody next of kin. So we try and get in contact with them. If no parents are there, we start our assessment. I sometimes join up with the other therapists, or if I'm on my own, I just see the child on my own.
Okay.
It's useful to join work because I'm on my own. It's just easier sometimes if you need to move and handle a child. Having some pair of hands would be really good.
Okay.
But if it's just assessments, and I prefer to be on my own, if I'm just assessing or talking to parents and stuff, then I go in there and also speak to the attending nurse. So it gives you a lot of information just doing that. I don't actively need to move the child because they'll be all in tubes and everything. But at least I know what I need to do next.
Okay.
And anticipate and plan when they move down to the ward.
Okay.
And also look into referring to community services, looking at community support.
So so you're already there, and what you've been doing in critical care is that you are already creating a picture of who this child is, what the child was doing.
Yeah.
And then
establishing pre-function.
Pre-functional, because that's really essential.
Is it pre-functional? No,
Yes, pre-morbid
pre-admission
function, pre-admission function.
Yeah, that's right. Yeah.
So you do that. And I think as a therapist, people are forgetting that the interview and knowing who the person is really very important, isn't it?
That is the key. How do you know what to do? Or how do you know how to facilitate anything if you don't know what they're doing before this happened? Because it's a different picture.
Yeah.
Seeing them there with all the tubes and all the lines.
Yeah.
It's different.
So that's what you do. You establish the baseline because that will be your target for setting the goals. And not just in critical care, but you're setting the goals. You have an overview of where the child's going to go, or what the pathway will be from critical care down to the ward, down to the community, or down to another service or another hospital if they need to be transferred, isn't it? So there is one of you, and that's the benefit, isn't it? I mean, not the benefit of you just being on your own. I mean, the benefit of having an OT there is whenever there are trauma services, you can have early assessment, early case planning. You can have an overview of the pathway in terms of the continuum of service. And so what do you do some intervention? Do you do splinting?
Oh, yeah, that's another one. So a lot of times referrals come in for upper limb assessment and splinting.
Yeah.
In the we do that. I can do that in the ICU.
Okay, so you do the splintings.
Yeah.
Okay. Can I ask you what kind of splints do you provide or do you make?
Well, usually upper limbs. I don't touch the lower limbs.
You
It's
don't?
upper limb splinting. I can make resting hand splints. It's just to maintain the tendon length, and especially when they're after major trauma, they are in a very awkward position. So it's just getting the hand in a good place, in a good position. So to maximize function once they regain consciousness or they regain the normal tone again.
Okay. So tone, it means these children have had some head injury.
Yeah,
an element of a head injury, isn't it? So you do some splintings, and I think that's very important, isn't it? Because wow, that's amazing. I'm actually quite jealous.
It's hard to do it in the ICU because with all the tubes and everything and the space constraint, that's a big challenge. So I try not to if I can avoid it, but if it's really important, then I would do it.
You would do it. Okay, so you would do that. Do you do like positioning and seating in ICU?
Yes, if they if they're ready to sit.
Okay.
If we are looking into positioning and moving from lying to seating, we try to use the bed or the cot initially just to increase the recline, slowly getting them to more upright position. We also use whatever's available. You need to be creative. Whatever's available in the ICU, you use up rolled blankets, pillows, everything to just if they're in an extensor tone, you want to break that extensor tone, so you need to use the blankets to move them into side lying or bend the legs, bend the hips, bend the arms. Now, once they're ready for seating, then I look into a supportive seating option, an activity chair usually, because I prefer an activity chair rather than a comfort. There are two different types of seating.
Okay.
Comfortable seating, which is your type of a recliner type thing. You just lie down. It's more like in a bed, but in a more kind of upright position.
Recline.
Activity chairs would have more support, but you are your core is supported so that you can be encouraged to use your hands better. So basically your feet supported, hips supported, knees supported, upper body is supported, and the head is supported, and all in midline and kind of thing. So it gives you that optimized position so you can engage.
Okay.
You can engage with your environment and with
And you do this in critical care or when they go to the ward?
You can. Again, it depends on your assessment. How ready are they? Is this important to do now? Because if the child is usually once they're in ICU and they're still not stable enough to go down the ward, yet in your assessment, this to increase their engagement, it will be important to start doing this positioning now. Then I would do that.
Okay. So you've done it. You've done some wheelchair and seating.
Yeah.
Now, when you mentioned earlier on about the positioning that you've done. Have you ever influenced the positioning to a point that the nurses were educated and trained?
Usually, but I won't take all the credit for this. So sometimes when I do that, I joined with the physio.
Okay.
And between the two of us, because I said I'm on my own, and it's nice to do positioning, especially with bigger children, with another person. So between the two of us, nurses in the ICU, pediatric nurses in ICU are amazing.
Okay.
They're really involved.
Okay.
So they would sometimes join me. If not the physios, they will join me, and we do that, experimenting, looking at positioning. And then we take pictures
Okay.
on our
On your digital platform devices, yeah.
And we put that on the file.
You do?
So people can see it.
That's amazing.
Yeah.
So in critical care, this is amazing. So you're on digital. You have a digital platform where you have a smartphone that you can. There are many names out there. There's MetaVisions. There's Epic. There is. I guess there's a few hospital that's using that. There are also Cernas. There is eCare. There's lots of other digital platforms. But what I find interesting is that you have a smartphone that you can use, take a picture, and then upload it in the digital system. So this means that communication is passed on much better between clinicians. So that's good. And then, so some of the input that you can do, if it is necessary and if it is at some point essential, that you think it is essential and vital, you can arrange for specialized seats or chairs that is promoting activities for children in critical care.
You can, as I said, you can if resources will allow you. Again, this is a challenge that most services face.
Okay.
But if you have that capacity or you have that resource, then use it.
Okay.
Because it's really important.
I'm always just looking at the what should happen, because most of the time, as therapists, we're always adapting to having no resources. But really, the ideal thing is, you're right. So given the opportunity and there are resources, and should there be investment in the area, you would not think twice on this, won't you?
No,
you'll just go straight in, provide that early involvement, early seating, so that it will facilitate an early rehabilitation
Yes.
for these children. And it's a chair that is not comfort chair, it's an activity
It's an
chair.
activity chair.
And as you said, what I think is very important, there are two types of chair, isn't it? And the comfort chair, which are usually provided by nursing staff, and because you know, obviously nurses, and they wanted patients to be comfortable.
And it's also just for change in position.
And
So change in position, if it depends on what your goals are. So if your goal is to just transfer from a bed to a chair, and you just want the person to be comfortable
Then-
in a different position, in a sitting position, then the
Comfort chairs are good.
chairs are okay. So
Yeah.
that's why you have them in the wards, the adult wards, on your recliner chair and something. But if your purpose is to be able to engage, to be able to recognize your environment, to just be upright and be more supported in that position, so that the child or patient is ready for function. So imagine what you can do in a supported seating position. Your hands are free. You don't need to think about your balance. You don't need to wobble. Your legs are not dangling. Your feet's flat. You can feel yourself. There's proprioception there. There is that security, internal security. And then what can you do? All you need to do is to pay attention to your surrounding and use your hands.
wow.
So
Wow.
that's the purpose of an activity chair.
So given that choice, if you are there and if people invest on occupational therapy in a major trauma, you would be involved more in critical care, particularly with major trauma patients, because again, they would have head injury, they probably are likely to have spinal cord injury or major fractures, but you can be there early, you can get them engaging early. And that means it's an early restorative intervention, isn't it? You know, for these children. So without you, they're just recovering, but there is no facilitation of enhanced recovery. There's recovery, but it's not enhanced. And it's not early enhanced, isn't it? It's not early enhanced recovery. Everybody does. They do recover, but it's not enhanced. And the optimum service is to give the best service to these population, to the children who's had this. And you can do the splinting as early as possible, which means if you do the splinting, you are maintaining the integrity of the hands and the soft tissue length. And when you're maintaining that soft tissue length, it means that there will be less of a disability in the future, because those splintings are preventative intervention and maintenance, isn't it?
You reduce the disability in the future and contracture, which may impact on the intervention they need to receive in the long term. Like
Okay.
surgery, they don't need surgery, they won't need that, or they won't need, other things,
Wow.
by just the maintaining them
Wow.
at an early stage.
So that early stage of splinting and what you can do, this is exciting. I'm really excited. So you do that. People just don't see it. They just see it as a splint. But in fact, this splint will maintain the hand. If the hand is maintained in a good position, it won't be contracted. They would not need to see a surgeon to release these tendons in the future. They don't need to have active Botoxing, I guess. And whatever, it limits the disability of the person, which means they can potentially work in the future, isn't it?
Yeah.
And then they work in the future, they pay a tax. Okay, right. Now we just advance the just advance the case. What's the word? Overview or advanced visualization of anticipation of what can happen.
Yeah.
So that's critical care. I would imagine that. So you are encouraging enhanced engagement. That's what you
That's a
have been
good
doing.
term.
Yeah? Okay, we'll write that down. Enhanced engagement.
Enhanced engagement.
Have you ever done that? Have you ever been in a case where you're not worried about resistance, just took time, went in to see the child, and have had an actual session of engaging with the child? Have you done that in Crete?
Yeah.
Yeah?
In the ICU. Recently, I had a child with GBS.
Guillain. How do you pronounce that? Guillain-Barre Syndrome?
I heard it as Guillain-Barre Syndrome.
Guillain-Barre. Oh, right.
So GBS.
Okay.
At 3.
Okay.
A very early onset GBS.
So it's
of a flu.
neurological, the generalized weakness.
Because of a flu. And she was still at ICU when I first saw her. And she's very weak, generally very, very weak. So I joined with physio. We were able to get her out of the bed to a chair. And once she sat in the chair, she was left with me.
Yeah.
So I'm on my own with her in the chair. And looking at the chair, it's not really an activity chair. So I adapted whatever I have in the...
You grab pillows,
I grab
grab
footstool,
towels.
towels, or a box or something.
A box, yes.
Just to get the feet flat and get her to put pressure on... We just keep the feet stable, basically. And I got out some toys that she likes. So she likes Sonic, so we got Sonic and Paw Patrol and all those toys, and we started playing together. And luckily, she was very, very...
Okay.
She's very engaged.
So you got her to engage.
Yeah.
Okay.
Yeah. Although she was very weak and she was shaking, and we had a really good session. She got fatigued quickly, but
were the parents there?
Yeah, parents were there and they were happy to see her like that. They said it's the first time they've seen her since she was very unwell, doing something, and we draw some pictures together. I don't know how we did it, but she was just happy to sit and do something, and she used her hands. It wasn't the best,
And
creation.
how was her face? Did you see her face? How did she react to it?
She was very happy.
You see?
She was
That's
very
amazing,
happy.
isn't it?
She was, making jokes. Well, although you can see that she was tired. She just got tired so easily. But
So slurry
she
speech?
she was a bit slur. She won't talk much, but she was smiling, and then she would go on to the recline herself and rest for a bit, and then come back again.
She would.
So that's very therapeutic looking at that way, because she is already trying to engage her core doing that.
That's very nice.
Yeah, so that's a therapy on its own.
Yeah.
Just sitting her there and then moving up and down from the... So when you see patients like that, you just want to stay with them the whole day.
Okay.
But you're also limited. She's limited, but I think that was one of my best sessions in the ICU environment.
Okay.
So that's just one, and that's the most recent. But we had few before that.
Great.
That's actually...
So there you go, guys. For those of you who are listening, you can just see, and this is us. We're just talking about ICU, occupational therapy in ICU. But an ICU came into discussion because of our exploration of what we can do in major trauma. So the next question that I do not know is like how many major trauma cases are there at a given point in a week?
I don't know about the week, but the recent data we got from the lead.
Okay, yeah.
From the lead is, I think, about 170 in a year.
170 in a year. Divide that in 10
pediatric.
months. So in 10 months, yeah.
It can't be exact, but it's more than 100.
Yeah, so it's rough draft of the idea. So if you have 170 in a year, say in 10 months, that's an average of 17 cases in a month. That doesn't come and go very quickly, isn't it? Because they would stay for, how long would they stay for?
Oh, weeks sometimes. Depends on the severity. If they have so many specialties involved and they need to be cleared from all of them, orthopedic, neuro. The longest I think we've had since I started there, it's not even a year that I've been there. 3-4 weeks.
Okay. So you have 3 or 4 weeks of stay in the critical care facility, and that's
not just in the critical care. They move to the ward.
Okay.
So once they're stable, critical care alone maybe a week.
Okay. So it just means that if people are staying in critical care for a week, it just means that the patients were able to achieve that hemodynamically. They're stable internally, which means that they get into the ward afterwards, isn't it?
Yes, yeah.
And then you follow them up in the ward.
Yes,
So
yeah.
it's a smooth. So if you're there, then you don't need. People do not need to make referrals then, isn't it? From critical care to the ward, isn't it?
They just stay in my caseload.
Exactly. So
Because I'm on my own. Yeah.
imagine the amount of time that you would be saving. The nurses. So you're saving that. It's not unnecessary, but the extra work that the therapist will have to do, isn't it? So one is being involved so you can be involved early. You can facilitate early engagement of children. You can do some preventative measures such as splinting and seating. You can facilitate encouragement and recovery through advanced seating skills, and then you can stimulate them. You can get a person to do some activity. You can stimulate them by early engagement, and then after the critical care, they go to the ward. Once they go to the ward, you being involved as occupational therapist, being part of the major trauma team, it just means that the team can be comfortable and be confident that their patients are well looked after. There's nothing that's being missed, isn't it? And then you continue on with their therapy, early therapy, which is early engagement, and it is in the ward area, isn't
In
it?
the ward, this is where you start to really move towards planning to go.
Okay.
And although rehab is still there, and it doesn't become it is a priority, but it's also more about getting everything ready
Okay.
and assessing daily where is the best place for this child to go.
Okay.
Are we heading for home? Are we going for further rehab? So that's where you start planning all of these things. But of course, rehab is still a key to this. But as I said, with my current capacity, it becomes a lesser priority.
I understand. Now, going back to this, it's an ongoing dilemma and a problem, isn't it? I think because there's few occupational therapists around, your input then goes into the end stage, which is where do we go? Let's plan the transition, isn't it? But, it's the big but. If, for example, there are people allocated to this, will you be able to provide intensive rehab?
Oh, daily rehab.
Daily rehab,
that-
guys! Wow!
You need to. I think these children deserve daily rehab.
Wow!
And I would go for that.
Yeah, and I think daily rehab is amazing, and it's not just 1 hour, 2 hours, because once they've done the medications and the physiotherapists say have seen them for a good few minutes, 35, 45 an hour, okay, majority of the time is the time to engage and do something.
And also, when you say daily rehab, you're not just doing rehab, like a typical clinical rehab session. You're actually starting to establish routine for the child.
Yes.
So what would they normally do at home? Although in the hospital environment it's difficult, but you start to normalize
Yeah.
as much as you can. So you try and incorporate a program. That one I'm not successful, but that's it's a goal.
It's something you want to do.
It would have been great to start a routine for them, daily
Yes.
routine, a program that is there, and then therapists can sign up to it to say this is the time we can come on a daily basis. Physios at 1, speech at 2 or whatever, and OT maybe at 9. Yeah, doing that timetable, and then there's also the education team that can come. It depends on what age the child is. Usually school age, there is a teacher that can come. So you can start normalizing the day for the child.
There you go. And this is amazing because as I'm hearing from you, and this is for all of us listeners here, from an occupational therapist's perspective, the daily rehab is engagement. So routine would be the goal of occupational therapy.
yeah.
From waking up into sitting down, into going into school or attending school-based lessons, doing some iPad sessions or some leisure gaming stuff. This is the rehabilitation concept of occupational therapy, isn't it?
Yes. And for those children who also in the toileting stage, that you can look into a suitable toileting equipment for them in the ward. That'd be amazing if we can have something that is really child appropriate, like a potty chair in the
Wow.
ward. Because if it's the previous function, they are already independently toileting. Then they come in with all these problems. Then you can start working towards that goal with the parents about restarting toileting, and that has usually a good take with parents. Parents would always want that goal
Yes.
in toileting to be
A priority,
yeah, priority,
isn't it?
yes.
I know.
Because they go back to school after this,
Yeah.
and once you're in school, you don't want to be wearing a nappy.
Of course. And you know, I'd like to share with you some information. I'm almost known by some people that know me professionally as the toilet hygiene king. You know, because that's the one thing that I always priority, and I always ask, you know, whether a person can actually engage in their own toilet hygiene. That's it. I have this saying. I call it my bum, my business. Isn't it? Yeah. So the rehab that you would be doing, okay, and it's just me. I'm just you know, like putting an emphasis on this, and I'm reassuring you that whatever it is that you're doing, that will encompass throughout the length of the day, the routines and habits, things like that. This is the rehabilitation concept of occupational therapy. This is occupational therapy, which means you don't necessarily have to be with the patient for just 1 hour. You can be there as part until the routine is established.
Because it's anything that you do, anything that occupies your time, it's occupational therapy, isn't it?
Correct.
And it's from the very start of the day. So having a program is actually occupational therapy. But at the moment, who's doing that?
Oh my God.
I think there are some like this. The school team would do that sometimes, and if the child is in an educable stage, but not all gets that service, which I think will be a key.
Yes.
If an OT is there.
Yes.
From the
So
very
early
beginning.
engagement, quality service. Oh, come on, guys. This is occupational therapy, isn't it? This is amazing. And the way you're saying this now, Weng, you know, it feels like, I know we're trying to be professional here. It feels like I'm beginning to have a crush on you. How is an occupational therapist is faced with another occupational therapist who I am admiring professionally, really, because the concept is there. You're just saying all the most beautiful words that people should be hearing about. Okay. Going back, okay, let's stay on the topic. Say, if you are in the ward, in the absence of OT in the ward, then there is less chance of, well,
not everyone gets a program or a routine, although I'm not. Although there are other professionals who can do it too. They said the education team or sometimes the speech and language team, because they do the mouth hygiene, the speech and language. So sometimes they just put in a timetable, and we put our availability there. So the problem with being understaffed, you can't always pinpoint a time when you can go, which is a shame, because
Yeah, I know.
you're supposed to be starting this as an OT. You should be starting this, and yet you can't even give a time when
I
you can
know.
come. Just I feel bad
Yeah.
whenever I'm faced with that kind of a challenge, because
know.
I don't feel effective enough.
It's
Yeah.
like being in a relationship, isn't it? You have to be there early. I think occupational therapists are forgetting this. Occupational therapists need to be in early so that you can set the routines and habits, because all these routines and habits and the things that you do every day are all occupation. What's happening now is because there is no investment to the service, or nobody even knows what it is, or there's no advocate for occupational therapy. We get called in every now and again. So the big part of the day is actually there's no case managers to these things, although it happens naturally. But this is the core concept. This is a core domain of occupational therapy.
And I think also the selling point there is as well, the sooner you establish routine, the sooner you normalize the daily life of the patient, the sooner they would want to go home, and they would be ready to go home.
Yeah.
Either emotionally and physically. Of course, doctors, that's more the medical side of things. Once they're medically stable, there won't be a dilemma of I can't go home yet.
Of course.
Because you've already started that routine, and this is exactly what I would do at home. May not be not be exactly the same because it's a hospital environment, but the routine has started.
Yeah.
And they get more confident.
It doesn't come as a surprise.
No.
So when the doctors say, medically you're good to go.
Yeah.
And then the parents and the child, if the child can speak and communicate, they start panicking. It's like, how are we doing this?
Yeah.
Okay. And you haven't done anything yet because the house is not prepared. The environment is not ready. It's a surprise, isn't it?
Yeah.
So I think if you are there in the ward, one of the things that can happen is that you can have an early assessment of the environment.
Yeah.
The discharge environment.
That happens from the very beginning.
Exactly.
So you already establish what they have at home, what kind of, because you link in with your colleagues as well to say, they have stairs, the bedroom's upstairs. So what do you think? Maybe down the line, do you think they'll be able to climb stairs?
Okay.
Because if not, we can start looking into downstairs living and stuff like that. So there's already that collaboration between the therapists, what they're going to aim for and what we're planning alongside that.
So having an occupational therapist there, it gets a better rehab goal setting. Okay. Early rehab goal setting, more targeted goal setting, more specific goal setting, and more realistic goal setting. So early collaboration. So your rehabilitation is more what's the word? I lack the word. Updated, current, relevant. More relevant rehab planning, because you have already had a picture. That's what you would be doing as occupational therapists. So if there are more occupational therapists in trauma, you can have more relevant rehab planning, because you would have part of the OT assessment is having a thorough assessment of the home environment. And it's not just whether the bedroom is upstairs or downstairs. What are the challenges? Because it's not just the environment that you would be assessing. You're also assessing the psychosocial demands and the pressure from the parents, isn't it? What are the challenges that the parents are putting into the situation? Are they at work? Do they have siblings? Are they in school?
So that's all established in the interview.
In the interview, yeah.
Yes.
So having more occupational therapists, having more investment in occupational therapists, we are making sure that the rehabilitation plan and the goals are, what was my word again? Relevant, yeah, and specific and targeted. Okay, so you do that. Have you, I'll just pause a bit. Now, have you ever discharged a person straight home after a major trauma, and then they're in the ward? Do you get to discharge them home?
Yes.
You have?
Yeah, we have. Because once they stay in the hospital, of course, until they're medically fit. But as I said, from the very beginning, you're already planning what's best for this person, for this young person. And depending on the outcome of your assessment, the home environment, is it suitable? So there are the things that you need to be sure. Is the environment suitable? And if you say yes, that's fine. Does this need further rehab outside home? That's always the that's always like the dilemma of sending home if they need further rehab, because community cannot always provide intensive rehab. But sometimes, because of their length of stay in the ward, they're getting lots of input from the physios, and of course from us, bits of us. They become ready. So some of them become ready to go home instead of going somewhere else.
Okay.
So but that includes, having said that, that's also very tricky, because you get to link in and collaborate with the community services, the community therapists. They're the key to this.
Okay.
Because they need to make sure. I couldn't always do an access visit, especially if they're out of county.
Yeah.
So they would do the legwork. They would come out and do the assessment and feedback to you. This is the environment. This is what what's the current situation? Do they need a wheelchair? Can they walk? Can they do steps? All those things. So you pass on that to physios. What do you think about stairs? And you do the transfer. You it's a big kind of collaboration between community and acute therapists.
So if you're not there, if they don't invest on occupational therapist, you leave them to talk to the community.
Yes.
Good luck in understanding the
and
language of going home, isn't it?
Yeah.
But if they invest on you, it really saves them not just time, but headache. Isn't it? It saves them headache, but they should be thanking you.
Yes. This is why I'm involved now with this major trauma business case, because they understand the role of occupational therapy there. They can, as I said, you can compare between when we're there and when we're not.
Okay.
You can see the difference. It's like now I'm currently on leave from work, and the unmet needs are just picking up.
Yeah. And what I understand is this, because it's a major trauma, it technically would fall on the quaternary service. It is a specialist service, because not every hospital, there's not a lot of hospital in the region or in every region. There's only few trauma centers around the country. So that would be like in the likes of a specific spinal cord injury facility, like say Sheffield Hospital or
Great Mandeville,
Stoke Mandeville, which is a spinal cord injury as well, or some specialist service in Great Ormond Street, for example, if there are any. So transplant for pediatrics would be in Great Ormond Street. Some surgical hospitals, cardiorespiratory hospitals, say like Brompton Hospital, Harefield or Papworth Hospital. So this major trauma, again, so you're in a position where you would be looking after cross-county cases.
Yes. It's not specific to the region. It's out of county as well, yeah.
Out of county, which means if you have to get a person home, I would imagine getting the necessary equipment takes some time.
Yes.
Yes? And it's a lot of phone calls. It's a lot of begging. Can you please order this? I don't have a PIN to order the equipment for this.
Lots of MDT planning. Meetings. Lots of meetings.
Okay.
With pediatric meetings, it's a lot of professional. There's a lot of professionals involved.
Yeah.
It's always like a major meeting happening when you're doing a discharge planning meeting for pediatrics. And it's a lot of time dedicated to it. So again, that's one of the things that I have to prioritize because of the necessity to get them home as safe as possible and as timely as possible. But that takes up a lot of time.
Yeah.
Meetings.
And people don't know that you're doing this.
Yeah.
Because they don't see you in the ward. They think there's
You're
not a
not
lot
around.
of occupational therapists. But what they do not know is that behind the scenes, you are having to negotiate with a lot of MDTs in the county, out of the county.
What do you have? What kind of equipment
in
can you
varying
provide?
counties.
Yes.
Yeah. And then, wow. Oh, that's all I can say. Wow.
Because especially as well, pediatric equipments, they're not... they're very specialized sometimes, and they're various sizes, of course. What age group are you looking at? And it not all countries have the same types of equipment. So you almost have to have that specialist knowledge of equipment available.
Yeah.
Similar
Yeah.
but different
Jeez.
kind of thing. See, yeah.
I would, oh my goodness, whoever holds the budget, guys, whoever holds the budget for this hospital, I really am hoping that you would pay attention to this, because I think the key, so if you're not there, the discharge, the length of stay would be more longer.
We have a discharge planning nurse, she's amazing. But between the two of us, we coordinate really well.
See?
So
That's
yeah.
That's because you are coordinating. But what I'm saying is, to have an occupational therapist and to invest in occupational therapy, it just means that you are contributing a lot to a safe discharge, to a fast discharge, to a suitable discharge. Because I believe that if you see that the person is not safe to go home, you have that difficult position where you have to put your foot on the ground. Is that what you
Foot down.
Foot down. Yeah, you have to put your foot down to say, nope, not home, get this person to a rehab facility.
Yes.
Okay. So, and that's even more
Yes.
difficult as well, isn't it? Because you're having to contend against the popular professions like physiotherapists, I would imagine. When they say, no, go to community rehab, but they are pediatrics, for example, and they are, it's a head injury. So it means it's a restorative intervention. So there's more time for them to recover. And I would imagine that you'd want them to go to a specialist neuro rehab facility. Wow.
And also, I would listen to the community therapists as well when they say, no, the home isn't suitable at all.
Yeah.
And then you within the MDT, some people were saying, yeah, they can be discharged home. They're physically okay now to go back home. But then the community team says, even with this kind of equipment, it's still not safe. Then you need to be able to communicate that to the team, that this is going to be an unsafe discharge.
Right.
If we send this person home.
So
So what's our option? So we kind of discuss that option. So that's when we hold a complex discharge planning meeting to find out the best solution to this safe discharge, to this complex discharge.
So you're like the eyes and ears
In the
outside and the eyes and ears inside the
Inside.
hospital. Okay. And wow, that's all I can say. I hope you have a good emotional and psychological support, because all of these hard work for you is really potentially causing some kind of a psychological work trauma. It is a lot of hard work.
Yeah, I'm just trying to not get overwhelmed by
Okay.
it. I take it day by day, and looking at there's always what's that, a light at the end of the tunnel.
There's always a light at the end of the tunnel.
A
Okay.
cliche, but it's true. That's all you can do. Hope that someday there'll be better funding, and eventually grow up a team of occupational therapists,
Okay.
and that's likely to happen.
Okay.
I'm positive.
Okay, I am as well. I am very hopeful as well, because I think so. Major trauma. I think does it end in the ward, because I think
No, so this is the long-term plan. So I have noted down as well, because especially children, once they come out of the hospital, depending on a lot of them would have neurological conditions and everything after a major trauma. So you also support going back to normal routine community or going back to school. So that is something that you kind of follow through.
would you
Yeah.
even if you're working in the hospital?
Well, we follow that through with the community therapist. So proper handover, because once they're stable enough, you do your rehab, don't you?
Yes.
So whilst they are with you, you look at what's this called, school prerequisite kind of function. So if they're writing, if they're able to read, they're able to engage or type, whatever, you do that kind of assessment already, and you feed that back to the a community therapist. This is what's needed. And then they look into, and now you ask them about looking into schooling, going back to school, return to school and stuff, and what kind of support they'll need. So that happens while they're still in hospital sometimes.
Okay.
So you almost kind of easing them in back to that kind of environment, even while they're still in hospital.
So you are preparing them at the end of the day. So with a major trauma, I guess that's the word. And a part of the discharge planning is that you are preparing them where if they have to go home, then you prepare the home environment. You do all the necessary visits. You do all the necessary meetings between the MDTs. You find the right team that will support the person from a major trauma perspective. It's typically the therapy. But what I was trying to zero in on is what I wanted to clarify is once they're discharged from the hospital, say they're discharged from the hospital, and you have passed them on to the community care. They don't call you again, don't they?
Oh no.
Unless they want to thank you.
No, unless they have other questions
or complaints. Then that's the only time when they come back. Okay. So I think if things are done properly, then the chances of having to deal with the case again is quite small. The chances are small unless they want to come back and say thank you again, or they want to come back and complain about something. But that doesn't normally happen. So
unless they get readmitted.
But this time it's no longer a major trauma. They would be readmitted for something else. And if they're local, then yes, they will be readmitted onto the hospital where you're working. But if they are from a different county, then their first line of admission would be their local district general hospital, isn't it? So I think that's a very healthy conversation. This is a nice riot conversation. Do you think?
Yeah.
Yeah. Is it fun?
Yeah.
If I ask you again, would you come back to join us again in this conversation? Yeah.
Okay.
Yeah, that's wonderful. Okay. Let me just give some quick summary. So we started looking at occupational therapy and having occupational therapy in major trauma in pediatrics. So we looked at the possibility of an early identification. If there's an OT in A&E, then they would know who the patients are at the onset, and then you can anticipate and plan it, and then people don't have to make any referrals to occupational therapy anymore because it is part of the team, which means anybody. So if an OT is admitted to that team, or if an OT is part of that team, you don't necessarily need assessment or referrals, isn't it? Because all of that team's patients will technically be the major trauma team. Exactly, isn't it? So that's that. So it really saves time on that side. And then an early recovery and an enhanced recovery will take place, and some preventative interventions in critical care. And you can start working early and enhance that stimulation as early as possible in critical care. And once the person is in the ward, you can start having that rehabilitation. And then occupational therapists will be able to identify and provide some smooth transitory service to facilitate communication or between the hospital unit and then the community, the receiving services. And you would make some referrals as well to the appropriate rehab facilities, isn't it? Okay, I think that's in a nutshell. That's what we have spoken about. Okay. Wow, I'd say this is this is a very, very exciting conversation. It's a very exciting riot conversation, and I would consider it to be a relevant information involving occupational therapy. I would like to thank our guest today, Her name is Weng, and she is an occupational therapist. I am Hao. I am also an occupational therapist. Right, just remember, guys, anything you do matters and has an outcome. Until next time, bye.